I want to first tell you very briefly about two patients and then a few of the highlights in the development of the history of multiple myeloma over the years. The first is a patient, Sarah Newberry, a 39-year-old woman who developed severe back pain while stooping. And then 2 years later, her husband carried her from in front of the fireplace to the bed, and in so doing, both of her femurs fractured. She was subsequently admitted to St. Thomas Hospital in London and was treated with orange peel infusions, rhubarb pills, arrowroot, a mutton chop for food, and wine to drink, as well as a pint of porter, and most importantly, opiates. Unfortunately, as one might expect, she did not do well, and is the first well-documented patient, as far as I know, with multiple myeloma. Here is her photograph, and it does not require x-rays to realize that she had a lot of skeletal damage. The other patient that I want to mention to you is Mr. Alexander McBean, who was a respectable tradesman and felt a little run down, tired, went to the countryside to improve his health. And one day as he was walking, he stumbled and fell and was seized with a severe pain in his chest, scarcely able to breathe. He was able to find his way to the local inn and subsequent medical assistance, which consisted of the removal of a pound of blood. Mr. McBean said he was a little tired and weak afterward, but his pain disappeared. So, as some of you may think, maintenance therapy is a new sort of thing, but it is really not, because his physician then began maintenance therapy with the application of leeches to his skin to continue the loss of blood. However, 6 months or so later, his pain returned, a variety of medications were tried, and he was given steel and quinine. And with that treatment, his pain disappeared, and he did very, very well for 6 months. And then his disease returned, his pain, he went downhill. And on New Year's Day, 1846, he died. And at autopsy, this is a woodcut of the cells that were found in his bone marrow. And if you look at them, you will see that some have 2 and one has actually 3 nuclei. They have the oval appearance, the nucleus a little bit off center and so forth. And I think that a morphologist today, a pathologist, would accept this as consistent with multiple myeloma. Now, there was another aspect of Mr. McBean that is very important, and that is his urine. His physician took a sample of the urine and boiled it, and it became, quote, slightly opaque, that is, a precipitate occurred, but as he continued to heat it, the precipitate, the cloudiness disappeared, and when it reached the boiling point, it was perfectly clear. Then, as the urine cooled, the precipitate reoccurred, and he said, "What is it?" A very good question. And he sent this to one Henry Bence Jones, who was an interesting individual on his own, but please note that his last name is plain, simple Jones. There is no hyphen in the Bence Jones. The Bence was simply the name of his maternal grandfather, and the hyphen was actually added to the name Bence Jones 50 years after Dr. Jones had died. This is Dr. Jones. He died at the age of 59, and so I think we would all agree, looks a little mature for his number of years. In any event, he studied the urine and made the statement that I hardly need remark on the importance of seeking for this oxide of albumin, which is wrong, of course, in other cases of Maltese and fragilistus osseum, that is, softening and holes in the bones. He was right on there. He was not only a chemical pathologist, but he was also a well-known physician of the day. Charles Darwin was one of his patients, and Darwin complained that Jones had put him on a very strict diet that was very difficult to follow. Thomas Huxley, a well-known biologist at the time, Hoffman, a chemist, well-known chemist, Michael Faraday, who did a lot of experiments in physics and electricity, were all his personal patients. Dr. Jones also described xanthine crystals in the urine, did diffusion studies on the body using lithium and quinine, wrote about diabetes, tuberculosis, but in both of his very large obituaries, there is absolutely no mention of this peculiar protein. The only reason, for example, that we remember his name today. Now, speaking of names, how did we get the name of multiple myeloma? Well, thanks to Dr. von Rutsky in Kiev, Russia, he did an autopsy on a 47-year-old man who had had a lot of bone pain and developed paralysis. And at autopsy, he found 8 separate tumors. In other words, obviously multiple. And of course, these tumors were in the bone marrow, and that is the term related to these tumors being in the bone marrow. This disease was called von Rutsky's disease for quite a number of years in Russia. And the other person whose name is very familiar to the field is that of Professor Otto Koller, a German professor who was born and raised in Prague, studied in Paris. In fact, he was more interested in neuropathology, wrote several papers on tabes dorsalis and the like, but he talked about a patient, and this patient, I should mention in passing that Dr. Collar, a very bright future, developed a lesion on his tongue, which turned out to be cancer of the tongue, died at 44 before he was able to realize his contributions to medicine. In any event, we know Dr. Collar as the person who described the history, published this paper on Dr. Luce, an obstetrician who developed chest pain in 1879. 2 years later was found to have protein in his urine. It was called albuminuria, but Willy Cuny, the very well-known German chemist, identified it as the very same protein that Henry Bence-Jones had described 30 plus years before. The patient developed pallor, presumably from anemia, had an episode or two of pneumonia, was seen in consultation by Dr. Collar, who noted his severe kyphosis, that is, and his chin, which was forced forward, caused an ulceration of the skin over his sternum here, and lost 6 or 7 inches in height. He had 6 grams of protein, which is quite a sizable amount, as many of you will recognize, and then died in 1887. Here is a man who, and stop and think for just a minute, who lived for 8 years with an obviously progressive, serious disease, and we don't know why. A few other points. Herrick was a very well-known internist in Chicago and described the first case in the United States in 1898, just 3 years after the discovery of X-rays by Röntgen. Dr. Wright recognized that there were holes in the bones if one took pictures of them by X-ray. It wasn't until 1928 that it was noted that there was a high level of protein in the patients with myeloma, their blood. And then came a diagnostic procedure, bone marrow aspiration, also from Russia. And this increased the recognition of the disease, as you can imagine. Then the work of Tiselius in electrophoresis, separating the proteins on the basis of their electrical charge. But this was not really practical because it took one technician 1 day to examine the serum of one patient. Hardly a diagnostic test. But in 1951, Henry Kunkel from Rockefeller University, New York, working with Dr. Tiselius, came up with the idea of using filter paper as the supporting medium, and with that, this brought electrophoresis and the discovery of the M spikes in the serum, and opened the door to many, many things over the next half century. Now, in my medical school textbook, Cecil's textbook of medicine, which was a standard in the vast majority of medical schools in the country at that time, the book was huge, 1,750 odd pages. One page was devoted to multiple myeloma, and prognosis and therapy is in the very last paragraph of this page. Prognosis, fatal. Treatment, Röntgen ray exposure, that is radiation therapy to the lesions. And secondly, blood transfusion. Not so good. Then, in 1947, Professor Nils Alwell from Sweden published 2 patients' histories who had been treated with this drug you see on your right called urethane, reported that the protein in the blood decreased and that the plasma cells in the bone marrow became lower. And on that basis, urethane was the only drug for the treatment of multiple myeloma for the next 10 years. Then the Eastern Solid Tumor Group got on the ball, so to speak, and reported a trial that they did comparing the active drug urethane and a placebo. And the placebo consisted of cola syrup. Okay? And here is the survival curve. It is basically the same. In fact, there's a little bend in the curve with placebo, suggesting the possibility that this might even be a little better than the drug. And in retrospect, the drug was not easy to take. It frequently caused nausea and vomiting and oftentimes diarrhea. And it's easy to see that some patients may have become dehydrated and precipitated acute kidney failure from the Bence-Jones protein in their urine. We don't know that, but that is certainly a possibility. So this is pretty much ground zero for the treatment of multiple myeloma. However, in 1958, during the height of the Cold War, and some of you may be old enough to remember that, a Russian professor, Professor Blokin, described this medication that he called L-sarcolysin. We recognize it today as phenylalanine mustard or melphalan or Alkeran. This was the first drug that had a beneficial effect upon this disease. The other notable event over this 40 or 50 year period was the report of autologous stem cell transplant by Tim McIlwain at the Royal Marsden Hospital just outside of London. He had a patient with plasma cell leukemia, which, as many of you know, is a leukemic form of multiple myeloma with many of the abnormal plasma cells not only in the bone marrow, but circulating in the blood, and thus a leukemic process. Well, he took a deep breath and a lot of courage and gave this patient 140 milligrams of melphalan per meter squared intravenously. Many physicians at the time would have said this would be a complete disaster and that the physician had just done the patient in, and he almost did so. Patient had, as you would expect, very, very low white counts for many weeks, very low platelets, and there were no platelet transfusions at that time. But the patient did recover. Bone marrow now had no myeloma cells, so Dr. McIlwain collected those stem cells from the bone marrow at that time. And then some months later, of course, as you would expect, the patient relapsed. His plasma cell leukemia came back again, and this time he was given his stem cells and then was given a large dose of melphalan, and then his stem cells were reinfused, and the patient did well after this procedure for a matter of a number of months and was a leap forward. These two things are basically the only advances that were made for almost a half century. During this time, everyone had various combinations of alkylating agents. Yours was better than mine was better than the next fellow's, and then in a very sobering meta-analysis in which 5,000 patients, as I recall, were reported, and it was found that there was no difference in survival, whether the patient received just plain ordinary melphalan and prednisone by mouth, or had any one of these combinations of alkylating agents with a number of other drugs tossed in. So this is what we had after 50 years of diligent work by many people. And then came thalidomide in 1999, and this is a story. Thalidomide was a drug that was developed in the 1950s, in the mid-1950s, given to women for nausea and vomiting of pregnancy and also for their nerves. And this led to a very, very serious developmental problem in the children who survived the pregnancy. And this drug, fortunately, was banned before it could be approved for use in the United States. And then it was reintroduced in 1999, just 20 years ago, with very, very impressive safeguards as far as pregnancy was concerned, and this was the first of the novel agents. This was followed by Velcade or bortezomib, and then Revlimid, which many of you patients have had or are taking. And then a third immunomodulatory drug, pomalidomide or Pomalyst, carfilzomib, another Velcade-like drug, Kyprolis, and more recently, ixazomib, Ninlaro, an oral drug similar to Velcade, elotuzumab, and more recently daratumumab, which is a very active drug and is well tolerated, and we're now learning that it's a very important drug for primary amyloidosis. And currently we have new avenues, immunotherapies. No one knows what these will contribute, but they are certainly very, very promising, and you will learn more about them in the sessions today. And thank you for your attention, and we'll get on to the meat of the meetings.